What physical therapists need to know about knee osteoarthritis. What's going on, guys? My name is Dan Pope. This is Kevin Coughlin. We are physical therapists at Champion PT and Performance. Like always, we're doing deep dives on the literature. We learn some stuff. Hopefully, you guys learn some stuff. We'll add our commentary, which sometimes helpful, sometimes not, but it'll be fun regardless. How's it going, Kevin?
It's going well. Yeah, that was an intense intro to Knee OA. So you sound excited. I'm excited.
It's important, man. Knee OA is a very important topic, so we got to get amped up for it. Boom. What are we going to go over today? So let me summarize it for you. We're going to go over the background of knee OA, prevalence and incidence, what populations most commonly have it, risk factors for it, comorbidities, pathogenesis, and pathophysiology. Fancy way of saying how does this happen in our bodies over the course of time, clinical examination, imaging, and differential diagnosis. Let's dig in. First, a little definition and background. Osteoarthritis, or OA, is a disease of movable joints characterized by anatomical and physiological abnormalities such as cartilage degradation, bone remodeling, osteophyte formation, joint inflammation, and loss of normal joint function, also known as Uncle Arthur. Comes for us all over time. I do want to stress this idea of total joint disease, just because osteoarthritis is sometimes poorly defined because you have an injury to the cartilage, but also to the bone, the synovium. There's a lot of stuff going on. The muscles eventually get involved, the ligaments. It really is a total joint disease, right? It's not just like a loss of cartilage. And it generally begins with micro and macro trauma to the joint. And I'm trying to simplify this because when I was doing a literature review on this, and this started years ago, it's pretty complicated. There's a lot of processes that go on that can create osteoarthritis. And I want to try to simplify it as much as possible without oversimplifying it, right? And giving you inaccurate information, right? But essentially, this could be from excessive use over the course of time. Think about elite level sports. If you look through the data that we have about risk factors for osteoarthritis, elite sports is almost always at the top, right? Obviously, going to change based on the sport and the joint and even like what component. So if you look at elite Olympic lifters, they have more patellofemoral arthritis. If you look at elite soccer players, they have more tibiofemoral arthritis. But if you do enough activity, right, you get to the point where you create more osteoarthritis than the average person, right? And the other way this can occur is through macro trauma. So we think about having an ACL injury, traumatic injury to the joint, maybe you have a big bone bruise, meniscus damage, something along those lines. That's going to accelerate osteoarthritis as well. So you do have this low level of inflammation, a little bit more breakdown, a little less buildup that causes osteoarthritis over the course of time. You can also have macro trauma, like an ACL injury, that creates more osteoarthritis. Excusez-moi, but I've got something pretty juicy for you. Boom! It's an evidence-based guide to knee osteoarthritis. Uncle Arthur comes for all of us over the course of time, and for your patients, it's no different. But if you've got this cheat sheet, then you'll be ready. Let's face it, nobody has time to stay on top of all the papers coming out on a regular basis that make you a really good coach and clinician. Luckily, you have psychopaths like me who love reading through this stuff, summarizing it, and putting it into a nice little cheat sheet. And my promise to you is I'm going to catch you up on the latest research in under 10 minutes. We go over prevalence, weight loss, risk factors, whether or not competing in a sport increases rates of osteoarthritis, and whether or not strength training slows down the rate of arthritis. We go over pathophysiology, clinical presentation, diagnosis, rehabilitation, and management. Best of all, this thing is 100% free. I'll leave a link in the description below. Go ahead and click on that and get up to date on your favorite knee injury, good old arthritis. Now, back to your learning. Background. You like this image here, Kevin?
I like that a lot.
Money, 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 money. So these are some cool stats, right? But essentially, as I was saying, trauma activates a maladaptive recovery reaction. So normally in our bodies, if we have damage, we want to make sure that we recover that fully. In osteoarthritis, we have damage, it doesn't recover fully, which causes more damage over the course of time, leads to abnormal tissue metabolism. And it's a very major cause of chronic pain and disability worldwide. It's actually number 2 next to low back pain. I don't think anything's ever going to beat low back pain. But osteoarthritis is close and has a very substantial impact on patient health and the economy, which I think is very interesting. So this is a problem for patients' health, but it's also a problem for you and I because we pay tax dollars to support folks that have knee osteoarthritis. So it behooves our society to be healthier, right? That's why I'm a big proponent of trying to keep people exercising, particularly when they have an injury. So there is an annual economic burden of 89 billion USD dollars, which is basically 1 to 3% of a large country's GDP, right? This is mostly coming in the form of joint replacements. So it's very expensive to do a ton of joint replacements and pay all the staff and everyone involved for joint replacements, particularly if a government covers your healthcare, right? So it's expensive. That's a lot. 3% of all the money allocated for GDP is going towards joint replacements. Not nearly, but close. And wages lost due to osteoarthritis amount to 65 billion. And direct medical costs exceed 100 billion. It's nuts, right? So if your knee is killing you, can't work. And it costs a lot. So you're going to doctor's visits, right? You're getting surgery. Kind of wild. So also, it's very expensive for the individual. So persons with knee osteoarthritis spend on average around $15,000 over the course of their lifetimes on direct medical costs of osteoarthritis, right? And it's probably a lot more for folks that go down that, pathway of getting surgery, right? Because there's a lot of folks have OA, and maybe they're just spending money on a couple drugs or some supplements, something along those lines. And there's folks that need a joint replacement, multiple joint replacements. It gets very, very expensive for the individual, right? Joint OA typically progresses from intermittent pain during exercise. So usually it hurts to do activity. And then it becomes more persistent chronic pain. It can hurt kind of up and down based on the day, doing absolutely nothing, right? Pain and stiffness contributes to functional limitations with a well-documented relationship between pain severity and the degree of functional limitation. If your knee hurts a lot, stairs can be hard, getting out of bed can be hard. All that stuff gets more challenging when pain goes up. Little information, on prevalence and population. OA is the most common musculoskeletal disease worldwide. This kind of contradicts what I previously said about low back pain, but I just took it from a research study. Take it with a grain of salt, I guess. Counts for around 85% of all osteoarthritis cases worldwide. I thought this was pretty interesting. So in terms of OA, there's a lot of it out there. It's most common in the knee, with a substantial majority being osteoarthritis in the knee. Because you also have the hip, you have the ankle, you have all the joints in the body that can be affected by osteoarthritis. Knee is by far the most common, right? An estimated 250 million folks suffer from knee osteoarthritis worldwide. This is symptomatic osteoarthritis, and rates are rising over the course of time, probably because we're living a little longer and there's more obesity, right? There's a lifetime risk of developing symptomatic knee osteoarthritis. Around 45% of folks. I know a lot of folks will say that, osteoarthritis doesn't matter just because it's not always symptomatic, and there's truth to that. But keep in mind, lifetime risk of symptomatic osteoarthritis is a coin flip, 50% chance, right? It's kind of wild. And 40% men and 47% women. We'll discuss this later, but women have a higher incidence of osteoarthritis versus men. This risk increases to 60% in obese individuals, which is basically most folks in the United States, which is approximately twice as high as a risk in those who are normal weight or underweight. So if you're overweight, your risk of OA doubles, right? 13.9% of adults aged 25 years and older have clinical osteoarthritis in at least one joint, whereas 33% of adults aged 65 years and older are affected. What that means to me is that it happens more as you age, right? And we talk about the pathogenesis in a minute. It's going to make sense. It's not as common to have osteoarthritis as a 14-year-old. It's more common when you're 86 years old, right? Nearly 30% of individuals greater than 45 years old have radiographic evidence of knee OA, and about half of them have knee symptoms. So I thought this was interesting, and we'll talk about the grading of osteoarthritis in a minute. So if you have a worse grade, you probably have more likelihood of having symptoms, right? But about half of these folks that have knee OA have symptoms, half don't, right? And this is also interesting. All patients with radiographic OA do not have a clinical condition, and all patients with joint symptoms do not demonstrate radiographic OA. So essentially, you can have basically no joint left over and have absolutely no pain, or you can have a little bit of osteoarthritis and have severe disabling pain. I've talked to some surgeons about this. I even saw a hip replacement at one point where the surgeon didn't really want to do surgery, and the patient ended up getting a hip replacement. And I remember watching the surgery. We looked at the hip joint and actually looked half decent, and they were getting a hip replacement. So this person obviously had disabling pain, and they didn't have a lot of degradation. And subsequently, the surgeon didn't want to do surgery. I have no idea how the patient did in the future, but just goes to say that you can have a lot of arthritis and very little pain, or you can have no damage or very minimal damage and still have a lot of pain too. What are some risk factors for osteoarthritis? Well, there's a lot of them, and this is where things get a little more complicated. So the big one, and this is kind of what we thought was the most important variable back in the day, are mechanical forces. And this is well documented. So occupations with frequent kneeling and squatting. So if you look at studies in China where folks spend a lot of time in their occupation squatting, you'll note that the incidence of osteoarthritis and symptomatic osteoarthritis goes up linearly for the most part with the amount of squatting that these folks do in their profession. Like I said previously, elite and professional sports is generally going to be more osteoarthritis, and usually it seems to be a dose thing. So the more miles you run, so there is a big study in JSPT, maybe Kevin can speak to this a little bit more. So I want to say it was like, now at this point, 4 or 5 years old, but big study, lots of runners. And what they showed is that if you compete at an elite level or national level, your risk of osteoarthritis goes up. Or if you run more than, I think it said 52 miles per week, your risk of osteoarthritis goes up compared to a sedentary population. So yes, if you do too much, that can cause problems. And like I said previously, if you have an ACL tear, that's going to predispose you to future OA as well. Okay. The other risk factor that's well documented is obesity. And those with obesity have 4 times the risk of knee osteoarthritis compared to normal weight controls. I always think it's funny because I'm taking these numbers from different studies and they're taking their data from different surveys. And this just contradicts what I said 2 slides ago. But having obesity is going to increase your risk. That's going to be a little variable from study to study. Next, female sex. Women are more likely to acquire knee osteoarthritis. Genetics play a role, which I thought was very interesting. There are 90 genetic risk loci. This study, I think, was from 2022. So maybe there's more they found now. I had to look up what a loci was, a risk loci, because I didn't really know what that meant. Risk loci is a specific fixed location on a chromosome where a gene or genetic marker is located. It is associated with an increased risk of developing a particular disease or condition. I've identified 90 of these, which increase your risk of knee osteoarthritis. So yes, there definitely is a genetic component. We're learning more about this over the course of time. And race. So largely African Americans are more likely to develop knee osteoarthritis versus other races. This is interesting because it's not the same for hip osteoarthritis. So there's something going on for knee versus hip, but you will see African Americans being at a greater risk. I feel like I need to take a break here because I'm tired. This is a lot of information, Kevin. So what do you think so far with all this information?
Yeah, it's good stuff. And I think it is a good intro to a future episode we're going to do on non-operative treatments for knee osteoarthritis, because a lot of the things you're talking about are places where we can intervene and hopefully help our patients have a better outcome. I think one of the interesting ones that you see, and whether it's sometimes someone gets an imaging for something unrelated or only partially related, and they find out they have really bad arthritis in their knee, and then they're all worried about what they should and shouldn't keep doing because they're afraid that they're going to make their arthritis worse. And there is a paper that I'll talk about in that future episode where it's a narrative review, and they poll patients with arthritis and clinicians who treat them and basically get their thoughts on arthritis. What does it mean to live with arthritis? And a lot of them are fearful that basic activities that we know will be helpful for them are going to make the joint worse. So, that's always a tough place to navigate, because if someone has bad symptoms clinically and on imaging they have bad arthritis and they've failed PT, those are the people we tend to send off for a knee replacement. But it's these folks who maybe weren't in the medical system. For some reason, they had imaging on their knee and they find out they have really bad arthritis, but they don't have bad symptoms. And then we might be creating someone who's going to end up with a knee replacement who might not have needed one because they're restricting activity. And as you said, their obesity is a big factor in this. So they stop doing the things that they like to do because they think it's going to make them worse. And then they gain weight or they get less metabolically healthy. And then they start getting bad clinical symptoms. So, there's so many places we could intervene here that I think is hopeful. And like you said, it would be good for everybody because it's so expensive. And when we do get into that future episode too, there's some projections on the number of knee replacements done annually in 2030 and 2040, 2050. They go by decade, and the numbers at the current rates are just like staggeringly high every 10 years. So hopefully something we can start working on sooner and get better outcomes with. But I just think, a few of those things you had mentioned are a lot of places we can intervene. So we'll definitely talk about that in the future. So good stuff.
Yeah, that's going to be a really cool discussion. So I'm not going to give them my thoughts right now, but interestingly, the paper I just mentioned, that was in I forget the name of the journal. You guys can definitely check it out, but they were talking a lot about genetic reasons for osteoarthritis. And they were talking about joint replacements being a major failure in the orthopedic world, just because they're trying hard to figure out why osteoarthritis is occurring and trying to figure out interventions that stop the process. Because when you're getting a joint replacement, it means everything's gone wrong for a long time. And the paper was just remarking that it's a failure on our part, not being able to figure out why and intervene sooner, right? Which I think that physical therapists can definitely have a huge impact here, right? And we'll talk about this in a later episode, because I think that when I just reflecting on my last 15 minutes of talking, I'm kind of painting a negative picture here, but I do want to state the facts a little bit so people are armed with that information, right? But yeah, a moderate amount of exercise is one of the best possible things you can do. But I also want to make this statement because sometimes I think we see things too much through rosy glasses, that all amounts of activity is fine. And you and I, we work in a sports setting. So we see a crazy number of ACL reconstructions, right? We see people that are pushing the envelope maximally. The amount of activity that they're doing is potentially too much. And sometimes there's a thought that that's fine. It's okay. And in reality, it's probably a little much, right? We want to be as healthy as possible. And it's important that people probably just understand this. And I think most people do, right? And I think the majority of folks that other PTs work with, they're chronic underdoers, right? And I just want to make sure that you see this through the context of the person you're working with. And most people, they definitely need to move more, but some people move a little too much too, right?
Yeah, I think real quick on that note of that running study you had talked about, I think with that study, there was like a Goldilocks effect where those people who they analyzed who didn't run at all and people who ran excessive mileage, whether it was somewhere over 50 or over 70 miles a week, had higher rates of arthritis. But then those folks that were doing a moderate amount, probably something between like 20 and 40 miles a week, which is a good amount. I mean, that's a good amount of activity. You're probably running for, 5 to 7 hours per week, had lower rates of arthritis. So I think, that's where we can be in the business of helping people find that balance of activity and balancing that with other types of activity, definitely strength training and all the other good stuff we like to do. But we do see both extremes. And I think as a country, we probably are too far in the little activity, but then in certain populations, we're definitely too far in too much activity. So, there's always the balance of in that realm, balancing performance and health, because we know that if you're striving for extreme performance, it comes with a risk to your health most of the time. We're not designed to push the envelope 24/7 for year after year after year, but it's, it is fun to do, but we just know that comes with risks.
Yeah, I think it comes down to knowing the person that's in front of you, right? Because even in the athletes, I think we're starting to see more and more of this in the ACL world too. After an ACL reconstruction or physical activity goes down, And there's a whole host of problems that come with that as well. One
Mhm.
of which being longer term osteoarthritis. So even for those folks that appear to be kind of elite level that, train at a high level, we don't want to scare them from exercise. It's really important
Mhm.
that we don't do that, because we do know that on average, these folks are going to get less healthy over the course of time because of this injury. So I'm always promoting exercise, always, always,
Mhm.
always. But we have to be cautious about how much, right? This is a very interesting slide, and almost didn't fit in the presentation, but I feel like I had to keep it in. But we have a number of potential pain drivers in osteoarthritis, maybe not potential cause, but maybe related from a cause perspective. A lot of that hasn't been ironed out a lot. But one of the big things that you'll see a lot in the social media world is more folks being aware of things like sleep and stress affecting pain. And I've read some of this in prior studies. And essentially, this is coming from the knee osteoarthritis world, but sleep does seem to be correlated with pain. So Wang et al. Demonstrated that sleep disturbances at baseline predicted the risk of knee pain and catastrophizing in 48 months. So if we're not sleeping well, that can predict your pain, right? And some studies even see that not sleeping well the night prior predicts your next day pain, right? And this is not just in knee osteoarthritis, but if you don't sleep well, you don't recover well. So if we're trying to get out of pain, we're not sleeping well, that's going to be a problem. And if you don't sleep well for a longer period of time, that increases your risk of having pain in the future too. So sleep is very, very important, right? So I want to make sure that we think about that as a potential reason why folks are having trouble. Another study, Zhao et al. Included 11,000, so high-powered study, patients with knee OA at baseline. And at the 4-year follow-up, the overall incidence of symptomatic knee osteoarthritis was 8%, right? Compared to those sleeping 7 to 8 hours per night, a short sleep duration, which is defined as less than 6 hours per night, was significantly associated with an increased risk of incident knee osteoarthritis. So kind of interesting, but we don't sleep. Is that increasing all the processes that create more osteoarthritis? Maybe. We'll talk about the pathogenesis in a minute. Sleep might be one of those things that influences recovery and inflammation in our body, so on and so forth. Probably important that we sleep. Kind of goes in line with like, don't smoke cigarettes and get drunk every night and get super stressed out, right? Those variables are probably pretty important, but really cool to see some research linking those things. So, comorbidities. We know that there are a lot of comorbidities associated with knee OA, and they could potentially be causative or a subsequence of, and they may end up blending together eventually. So we already spoke that there's a high incidence of high BMI and obesity with knee OA, and this is also the case when they control for adiposity and body fat percentage. So if you have a higher BMI and you have more muscle, right, and have your bones, more dense bones, I guess, your risk still does go up, right? It's not so having more adiposity increases your risk, but having a higher BMI does as well. And we all kind of know that having BMI doesn't mean you're fatter. Could mean you have more muscle and bone, but you will find studies that show once you control for body fat, the body weight is still a player. Body fat is worse than more muscle and denser bones, but you still have increased mechanical loading, right? And that sounds bad because the last thing you want to do is scare people from strength training because it's obviously good, but it does kind of lead to the thought process. I'm a gray guy, and I think things kind of sit on both ends of the spectrum. And I think a lot of folks will say, like, never say anything that dissuades folks from having increased body mass that comes from muscle and bone. We want to make sure that we promote activities that increase bone density and muscle mass. But you will see if you have too much of that, that can be a problem. But the big one is going to be increased adiposity. And that's obviously going to increase biomechanical loading. We'll talk in a minute about how increased adiposity may increase inflammation. I feel like I'm walking on eggshells here. I'm trying not to scare folks, but I want to be accurate with the data because I think sometimes on purpose, you'll see people looking through completely rose-colored glasses when they present information, and it's not entirely accurate. But I think it's important that we just promote health and health-promoting, muscle-building, bone-building activities and not scare people from exercising because I think it's going to make them worse.
Mhm.
So folks with osteoarthritis have higher risk of depression. This could be because they have more disability coming from pain. They generally have decreased physical activity, right? Which may lead to more osteoarthritis, and more pain may lead to more disability and less physical activity, and more, adiposity and obesity. It ends up being this vicious cycle, right? So more pain, more disability, less physical activity, more osteoarthritis, more obesity, more pain. It's a feed forward mechanism. It's a bad thing. We want to try to intervene upon this at some point. These folks have a slightly higher risk of cardiovascular and atherosclerosis disease. It's probably linked with obesity, right? We know obesity is bad for those. Those with knee osteoarthritis have a 20% increase in age-adjusted mortality. So basically, they have more comorbidities and decrease in physical activity. Makes sense. More cause of death from all causes, unfortunately, probably from these comorbidities and not knee osteoarthritis itself. I've never heard someone die from knee osteoarthritis. It got so bad they, just basically keeled over. But just keep in mind, knee osteoarthritis is associated with all these comorbidities. And it may be a feed forward mechanism because if your knee hurts a lot, you're not exercising, you're not getting stronger, that causes problems as well.
If you guys like what you're learning about so far, then the next logical step is to sign up for the Fitness Pain-Free mini course. I've made an absolutely free mini course, and we go over 4 vital lessons for coaches and clinicians. The first lesson goes over how traditional schooling has failed us. Now, I'm actually a really big fan of education, and I think that physical therapy school actually prepared me pretty well to work with the average person. However, I really didn't learn how to work with the population that I want, which is people in the strength and fitness world. So I'm talking about powerlifting, bodybuilding, Olympic weightlifting, sport of fitness, and really people that just love working hard in the gym. And really my goal with the mini course is to help you understand how you work with this population to get them out of pain and keep them training. The next lesson is 7 reasons why people get hurt in the gym. So it's vitally important they understand the injury mechanisms or why people get hurt in the gym. If we don't understand why folks are getting hurt in the gym, it's going to be very hard to rehabilitate those folks because let's say we do get them better, they go right back in the gym and get hurt in the same exact way they hurt before. The other piece is if we want to keep these folks safe for the long haul, we have to understand the main reason why these folks get hurt in the first place so we can keep them in the gym training as safe as possible and minimize that risk of future injury. Next, we go over 4 simple steps for getting your clients out of pain. Now, rehab can be very complicated. There's a lot of systems out there that make it very challenging to figure out how to work with your patients. However, it really doesn't have to be that complicated. So I go over 4 easy steps you can follow to get your patients out of pain and back in the gym where they belong. Lesson number 4 is how to build the career of your dreams and earn the respect of your community. Let's face it, the reason why you take these educational courses is obviously so you can learn a little bit more, but really the deep-seated reason is because you want to have the respect of your community. You want your clients to come in, work with you and say, wow, Joe was great. He did a phenomenal job with me. Tell their friends, and their friends come to see you. And after a while, you're very valued and respected within your community. So I'm going to teach you how to do that. The second piece is that if you know these skills, it doesn't always mean you have a ton of patients going through the door so you can work with the population you want to work with, right? So you may be the absolute best coach in the world, but no one wants to come and see you because they don't know who you are and they don't know how good you actually are. So we'll teach you how to get the patients through the door that you want to work with. And lastly, we'll talk a little bit about the Fitness Pain-Free certification. This is the largest and most comprehensive educational course that I offer, but more on this later. So I'll leave a link in the description, in the show notes. Again, it's 100% free, really easy to download. Go ahead and do that right now.
Any thoughts there, Kevin, before moving on?
Yeah, I think, when hearing you talk about that stuff, one reason why I enjoy doing the podcast with you so much is just more time seeing more studies, and then you see how they all kind of relate to each other to make your decision making better, but it makes things more gray too. And I think that's important because, I always think of like our boss, Mike, when one study comes out that says something, he gets all mad and he's like, this is just one study and it's designed poorly. And I think I think at this point, he's seen so many studies that he could draw those parallels. So I think when you talk about like too much muscle building or perhaps having a higher BMI, I mean, yeah, we can't just look at the positive studies on weight training and pretend that everything is going to be better for your health long term, although it probably is. But maybe it increases if your BMI is so high because you have so much muscle mass that maybe it's good for a bunch of other things related to your health, like you're optimizing your hormone health and your bone density, but maybe there's a little bit increased risk of knee OA. And I think the more we look through different studies, you see that it is gray, and it probably comes back to the patient in front of you and their goals. And if you have someone whose goal is to improve their aging, as like I kind of think of you now, right? Like you've transitioned to, you're trying to really age healthy. It seems like you kind of optimize your training around that. You're not lifting weights 7 days a week, probably like you used to. And, it comes back to the person's goals in front of you, but it's good to just know what the research says and compare it to all the other research you look at, and then kind of make a clinical judgment with the patient or the client you're working with to improve their long-term health. If that's their goal, I think there are good recommendations we can make, but it's always exciting to just see what different research says and compare it to other things we've learned, and then put it all together with the person in front of you.
Yeah, I I had this talk with a newer grad the other day, and we were talking about the same exact thing. And I think it's very challenging for new grads. I was in this boat for sure. I remember this. So essentially, you're getting hit with too much information, right? And that is happening from a research study perspective, but also from a lot of influencers online. You don't have a good background of experience to weigh anything against, right? So what happens is that you have a social media influencer come out, and I think he was specifically talking about Meekins and Greg Lehman, right?
Mhm.
And I think these guys are good in small doses for the new clinician, because they just flip every single idea that you have about physical therapy on its head completely, right? And that's kind of their brand. And I think that some of that is good because he really were critically reasoning about the research and our preconceived notions about things. Sometimes they're wrong, they need to change, right?
Mhm.
I think the other part is that you have this baseline as a physical therapist. And if you're getting like new study, new influence here and there, you're making like 180-degree turns every week. Like, oh, I can't do this. Now I can't do that. This study came out. I'm completely stopping this. When over the course of my career, what I found is that I'm like, okay, this study came out. That's interesting. I wonder if that'll be repeated over the course of time, right?
Mhm.
Or you maybe have a criticism of that study because you understand that these variables are important. They didn't control for that in the study, right? And you don't change your strategy completely from the get-go. And my advice too, and maybe this isn't the best advice, but sometimes I think that you want to find a couple experts or maybe a couple papers and essentially find a clinician that you kind of jive with, that works in a similar population as you as considered an expert, and learn from them, and put on a little bit of blinders for a while and get really good and follow one person for a bit and develop your own systems, and then eventually start to expand and branch out a little bit more, so because then you can set a better foundation and not just feel like every day you have to change everything that you do because you hear something that's so different. So it can be very confusing for new grads and students, just because there's so much research comes out that's contradictory, and there's so many voices and opinions in our world, so
Yeah. One thing I'll say quick, not to get too off topic, but I do think it's important, and is a reason I'm not really on social media, is I feel like there's too much crap out there. So I've done what you said, which is I subscribe to a few people who I really liked. I subscribe to their newsletters. Like I subscribe to you, I subscribe to Chris Johnson, I subscribe to Mike Reinold, I subscribe to David Gray, a few other people. And then I'm just reading a little bit longer form content, and they might send studies with some of the things they're talking about. And then you're reducing the filter a little bit of how much information you're getting, and then it's not so contradictory. And it's probably good to expand that library over time, but there has to be a limit. It can't just be every single thing you see, you're like, oh, I have to implement this now, or I used to think this, now this is wrong. And it's just, I think less but higher quality is kind of the theme I'm going for. And I think people are starting to see that. And, it's just interesting to think about. And it relates to this topic and all the topics we talk about.
yeah, for sure. Good points, man. We could do a whole episode about that, right?
Yeah.
Okay. Next, let's talk a little bit about the pathogenesis of osteoarthritis. Two things before we get going. This was complicated. It is complicated. It's very complex. And I will say I don't have the most thorough understanding. I would read through a whole paragraph about the pathogenesis of osteoarthritis. And A, I'd have to read it again. B, I couldn't understand half the words, right? So I'm going to try to simplify this as much as possible. If you want a better understanding of it, you can check some of the references. They go super in depth on how this occurs. And this is important because we're trying to figure out how osteoarthritis occurs so they can intervene, right? They have to figure out what's going on at the cellular level so they can kind of reverse engineer a solution so these things don't happen in our body, right? But it is important to understand that there are various factors that contribute to osteoarthritis. They can be mechanical. We just talked about this, right? They can be inflammatory, which we'll talk more about this. Aging plays a role. We know that over the course of time, we have more osteoarthritis, and metabolic disorders also play a role, right? Diabetes, blood sugar, increased adiposity, all that stuff can play a role, right? And these factors ultimately lead to structural joint destruction. Man, that's a tough word to hear. Destruction of your joint. Loss of synovial joint function and long-term chronic pain, right? We're just going to try to talk about how this is a total joint disease. It's not like just the cartilage is involved. You run out of cartilage, now you have arthritis. There's a lot of stuff that's occurring, and cartilage is just going to be one part of that. So we're going to go from area to area of the joint that becomes involved, so you can see just how this, progresses over the course of time. So articular cartilage is probably the biggest and most commonly cited area that osteoarthritis affects. So essentially, we talked about this. Mechanical loading to a moderate degree has a beneficial effect on cartilage metabolism. So one of the things that I'm going to try to speak towards is that over the course of your life, you have cartilage metabolism, which essentially means that some cartilage is going to break down and then build up over the course of time, right? And over the course of our life, this actually goes down, goes down, goes down. The cartilage within our knee is like the thickest cartilage we have in all of our body. So it makes sense that we have a lot for a reason. We're probably meant to have a little bit of, I'm going to use a word, wear and tear. I still like the word wear and tear, although I know a lot of folks, it's a very condescending word and scary word for a lot of folks, but you will have some wear over the course of your life, and that's normal. So what happens is you have a net breakdown, and then the buildup doesn't meet the amount of breakdown. And this is occurring at like a microscopic level. It's not like you lose 1 millimeter of cartilage day one, and then you build back 1 millimeter day two. So once you have enough damage, it doesn't come back. Our body doesn't regenerate cartilage to the best of my understanding and what I've read through these articles. So once you lose cartilage, it's not like you can build it back up, right? So be amazing if we can. Hopefully we can at some point. For the most part, doesn't seem to return, okay? We also have research to show that limb immobilization leads to articular cartilage thinning, right? So if you take someone's leg and just immobilize it, don't let them do any activity whatsoever, that's going to thin the cartilage. So we know that loading has a beneficial effect. It's good, right? But excessive loading leads to increased catabolic activity, so breakdown, and decreased anabolic activity. So it's basically classic overuse. You do too much, not enough recovery, you essentially have a net breakdown. And that leads to this irreversible destruction. These words sound terrible, right, as they come out of my mouth. I'm saying it to clinicians. Hopefully it's not just a bunch of folks. I know there will be that are listening to this and getting freaked out by this. But for the most part, from our understanding of cartilage, it doesn't regenerate. It's not like you have advanced osteoarthritis. You can just grow all your cartilage back. It doesn't tend to happen in our body, right? So it behooves us to try our best to moderate the amount of physical activity we do. You can do a lot without causing any damage. Exercise is very good. Again, I can't downplay that enough. The subchondral bone is also involved in osteoarthritis. What does that mean? It's the bone underneath of the cartilage. This undergoes modeling and remodeling in response to changes in a mechanical environment as well, right? So stress, mechanical stress, exercise, it's going to influence this bone. And with osteoarthritis, the subchondral bone thickens, gets bigger. The trabecular bone deteriorates, and eventually undergoes sclerosis, which is hardening, right? There's an alteration in the osteoclast and osteoblast activity. Remember that from undergrad or graduate school. Some of these are going to build up bone. Some of these are going to break down bone, which leads to subchondral bone lesions, cysts, and osteophytes. These bone marrow lesions are correlated with pain. So I know a lot of folks will say there's no correlation between osteoarthritis and pain. That's untrue. Some aspects of osteoarthritis don't correlate with pain well. Some do. These bone marrow lesions are correlated with pain, and they're also associated with neovascularization and growth of nerves. So one of the thoughts is that bone is already relatively sensitive. After you have osteoarthritis, you have more vessels that grow in the area, and you also have more nerves that grow in the area. Now you have the opportunity for more pain. So that's one of the thoughts as to why people have pain with osteoarthritis. We actually have denervation strategies as well as vessel damaging strategies, which are newer, where they're trying to reduce the blood flow or cut off the nerves to the area, which can show reduction in pain after knee osteoarthritis, which is kind of cool. But we have to figure out why folks have pain in knee osteoarthritis to figure out some interventions. So this is one of the things that's going on. We can also have changes within the synovium. So the synovial fluid as well as the synovial membrane undergoes changes. So the synovium is generally a reservoir for nutrients, which is good for the joint, right? But also houses degrading products, more particularly inflammatory macrophages. So one of the key aspects of osteoarthritis is that it's an inflammatory condition, and the synovium is going to house some of these inflammatory macrophages. It's a potential cause of inflammation and this kind of mechanism of decreased cartilage and pain over the course of time. And synovitis correlates strongly with pain in osteoarthritis. So again, another potential marker of osteoarthritis that does correlate with pain, right? This is based on WOMAC pain scores. If they see a lot of increased synovitis via MRI, that also correlates with pain on these WOMAC outcome measures, right? It's also associated with clinical and radiographic progression of osteoarthritis. So as osteoarthritis gets worse, you tend to see more synovial thickening, hardening, hypertrophy. Infrapatellar fat pad is also involved. We already know that this is a very sensitive structure. It's got a lot of nociception in it. What's also interesting is that the infrapatellar fat pad is an endocrine organ, right? It produces adipocytes and cytokines. Those are pro-inflammatory compounds. We also know that there's increased substance P in osteoarthritis, which is associated with pain and comes from that infrapatellar fat pad. So the fat pad might be taking stress, and as a result, it's creating inflammation, and that can continue osteoarthritis within the entire joint. So kind of cool. I didn't know that. It's kind of a unique finding, right? We also know a lot about the menisci, muscles, ligaments, and tendons potentially being involved with osteoarthritis if you've been watching the Fitness Pain Free podcast for a period of time now. So essentially, if you have damage to the meniscus, that's a strong risk factor for osteoarthritis, right? Particularly meniscectomy, right? If you get that meniscus repaired, maybe that reduces osteoarthritis. If you get the meniscectomy and just take parts of the meniscus out, increases the rate of osteoarthritis because it increases mechanical loading and or instability of the joint. We talked about the lateral meniscus being very important for joint congruency. You start taking chunks of that out, you're now making the joint a little bit less stable, increasing mechanical strain, increasing osteoarthritis, right? I didn't know this, but this is interesting. The periarticular muscles can become involved in knee osteoarthritis. So in OA, these muscles show increased inflammation, and muscles can produce something called a myokine, which is pro-inflammatory, right? So your friends, the muscles, they actually end up becoming your enemy a little bit, producing more inflammation in knee osteoarthritis. Obviously, muscles are important. We want to strength train them. So I'm not trying to say don't work your muscles, but it actually seems like the muscles contribute after a period of time with OA. We know that ligamentous and tendon injuries can be a predisposing risk factor for OA. Think about your ACL tears. They can increase mechanical loading and instability. So up to 50% of folks acquire knee OA after trauma. Think about your ACL injuries. A lot of those folks end up with OA long term. Next, we'll talk a little bit about cytokine involvement. Cytokines are the main signaling molecule from the immune system. Sorry if I start messing up my words. These are hard words, and I'm getting tired. Osteoarthritis characterized by the production of a low level of chronic inflammation. This is essentially an imbalance between inflammatory and anti-inflammatory stress, right? Cytokines being part of this. I took an image from one of the studies. It was open access here. Talks about pro-inflammatory factors, and there's a lot of them there. If you want to take a look at them, watch the YouTube version of this. And the anabolic factors. So the thought process being is that there's more pro-inflammatory factors and less anabolic factors, which eventually long-term leads to more osteoarthritis. And in OA, we have more pro-inflammatory cytokines. And like I said, this leads to a cascade of damage. Last one, Kevin, and then I'll let you talk a little bit. We'll talk about adipokines. I have an image of cookies here, which leads to more adipokines. So if we think about adipose, that's body fat, right? And our adipose actually produces inflammatory compounds, right? We know this. We see more of this in obese patients. So one of the thought processes is that if you are obese, it's going to lead to more mechanical loading of the joints. Obviously, you're heavier. It's more weight on the joints. But if you have more body fat, that's going to release adipokines, which are pro-inflammatory, which can also lead to more osteoarthritis over the course of time. So we don't fully understand, looking through the studies that I just, read through to make this presentation, the adipokines are thought to play a role in osteoarthritis progression, although we're not fully sure of that role. We just know that there is a positive association between obesity and osteoarthritis, and we believe that these adipokines might be part of it, right? And it might not just be mechanical loading, and cookies, when taken excessively, can lead to this.
Hey friend, if you're liking this content, I have something I think that you're really going to love. And that would be a master course on rotator cuff related pain and rotator cuff tears. Having the patient come through the door and you don't know how to treat their pathology, that stinks. You feel like a fraud, you're just making stuff up. It's not good stuff. It's also pretty dang tough staying on top of all the literature that's coming out all the time. Well, guess what? I have done this for you by making a master course on rotator cuff related pain. Well, what kind of stuff do you go over in this course? I've got an evidence-based guide. We go over diagnosis and special tests, my favorite beginner, intermediate, and advanced exercises, how to modify your patient's training in the gym so they can keep on working towards their goals and not hurt themselves more, my favorite evidence-based manual therapy techniques for these folks, case studies on how to treat non-op and post-op patients, as well as the exact rotator cuff related pain protocol that I give to my patients when they come to see me with this common issue. Now that sounds pretty good, Dan, but how much does this cost? How does $1 sound? Whoa, $1? That sounds crazy. Why is it so cheap? It's mostly because I don't know how to run a business, but I do know about the rotator cuff, and I'll teach you all about that. This all comes with a subscription to Fitness Pain for Insiders. It's $1 for a 1-week trial and $25 per month afterwards. However, you can cancel at any time. If you don't like it within the first 7 days, just tell me. I will cancel and refund for you. Plus, I have a lot of other really good courses in there as well. We have master courses for cervical radiculopathy, lumbar radicular pain, lateral ankle sprains, and what I'm working on next is, you guessed it, your favorite, shoulder instability. So click on that link in the description. It's $1. Go ahead and get started, and I'll see you on the inside.
Let's take a break. This is a lot. What are your thoughts here, Kevin? Anything to add at this point?
Yeah, I think, again, just the stuff you're highlighting now, I think relate to a future episode we'll do on treatments. But I think it is important to kind of reiterate that this is an inflammatory condition, because the use of anti-inflammatories can be helpful for managing symptoms with arthritis. It's not like our tendinopathies where we want to avoid long-term use of anti-inflammatories. This is a condition that is primarily inflammatory, and it seems like that cascade that you've been talking about can make symptoms worse over the course of time. So trying to find ways to halt that inflammatory process is going to be helpful for treatment. So that's why I think this information is important to know. And then I think the other thing is I did remember learning at some point, probably when I was in undergrad or something, that arthritis isn't simply a mechanical wear and tear, although that seems to be playing a role. But there's a lot of, this metabolic cascade. And maybe if we can do things to improve our metabolic health, we can do things to improve the symptoms of arthritis and that inflammatory process. So I think it's another reason to promote a healthy lifestyle and reduce adiposity if we can, because it's probably not good for the health of any of your joints. But that's not something we always think about when we think about our metabolic health, is what impact does this have on my joint pain? And it probably has a fairly big impact, I would think, based on all those inflammatory signals and markers you were just talking about. So I think that is important to keep in mind, is this is definitely primarily an inflammatory condition. So doing things to improve that will be helpful from a treatment standpoint.
Yeah, and I think what makes sense to me, and I wanted to be comprehensive here. And like I said, I'm not the biggest expert, so a lot of this information probably sound better for someone that knows this a little bit better to me. I want to be comprehensive. When I say all these things, it just gets complicated. What makes sense to me is this idea of cartilage homeostasis. And I don't remember where I read this, but we're essentially going through this process at all times where we break down some cartilage, then we build it back up again. If you look at like basketball players, their rates of cartilage turnover is very high, but it also is built up quickly. So there's a lot of mechanical loading, right? They play a sport, breakdown, build up, breakdown, build up, breakdown, build up. There's a lot of other factors that play a role, right? So if we have excessive inflammation, we have a little bit more breakdown and a little less built up, which over the course of time may accelerate osteoarthritis. It's just that there's a lot of variables that influence this, right? And we're trying our best to figure out how we can intervene. But like Kevin's saying, as physical therapists, we can do a lot, right? Because there's a lot of stuff that we can intervene upon. And it's not just the mechanical loading. It's like, hey, if we maintain a healthy lifestyle, we're going to influence the rates of adiposity. We're going to influence the rates of inflammation, right? We can point people towards having healthier habits with their life. And it probably will play a big role. But we'll go over that later. I feel like it's a little bit good cop, bad cop. I'm talking about all the bad stuff, and you're going to swoop in and talk about the good stuff. So, all right, let's talk about some clinical stuff, something you can actually take away here. So what is the clinical presentation of folks that have osteoarthritis? So classically, people that have knee OA tend to report pain and stiffness within the knee joint, right? And generally speaking, it's worse in the AM or after a prolonged sitting. For these folks, when they get out of bed, they're like the tin man. They're like, oh, I need some WD-40. I get, so stiff and painful, and they walk for a while, then it starts to get better, right? And they sit down on the couch, watch some TV, and get up again, like, stiff again. They need some more oil injection to the joint, right, to get them moving. But just to speak to the nature of exercise being beneficial, right? Exercise definitely makes them feel better. So, hopefully you can convince these folks to exercise more, because it seems like when they sit around, it doesn't help. And this I took directly from a study. While sometimes viewed as a disease of inexorable worsening, the natural history studies show that most patients report little change in symptoms over 6 years of observation. So I know you're going to speak about this in a future presentation, a future lesson, but a lot of folks have really poor beliefs around knee OA, one of which is that this is just going to get worse over the course of time. But if you look at some of the natural history studies, a lot of times it just maintains. It's not like this is definitely going to get better, or worse over the course of time. There's nothing I can do about it. For a lot of folks, it just kind of stays consistent. We also know that we intervene, it can improve, right? So I think patients really need to keep that in mind and to hear that over and over and over again, because we know that despite not being able to grow more cartilage, we can make your knee feel better. We get back to activities you like to do and give you less pain throughout the course of the day and improve your function, right? So that's definitely good stuff. From a physical examination perspective, what are you going to see? And this was interesting to me, but I did find some studies showing that there's generally minimal joint effusion with knee osteoarthritis, but this is not what I've seen as much of clinically, or maybe I'm just misdiagnosing things. But these folks will often present with a popliteal or a Baker's cyst in the posterior aspect of the knee. Essentially, there is swelling involved with these folks, right? A lot of swelling. There's not a lot of space in the knee, and the negative space where fluid can go is sometimes in the back of the joint, and that can form a popliteal cyst or a Baker cyst. So oftentimes these folks will get some imaging, and they're like, oh yeah, you have a Baker cyst in the back side of the knee there. It tends to just be where the fluid ends up going. But I thought it was interesting just reading that there's generally not too much joint effusion. And thinking back on my knee OA patients, I tend to see a decent amount of like swelling, right? But maybe that's more indicative of chronic meniscus issues or something along those lines, right? This is just something I read that kind of contradicts what I've seen. So who knows? These folks tend to have stiffness and pain with knee range of motion, particularly flexion. See this all the time. People with knee OA, they tend to lose knee flexion range of motion. Just hurts a lot, starts to feel really stiff as they bend their knee, right? You'll also potentially see some crepitus in these folks. It's a lot of snapping, crackling, popping. What I will say is that you can have quite a bit of crepitus without any knee osteoarthritis. So it's not like super sensitive or specific. And the other thing that I read was that this is potentially indicative of more patellofemoral arthritis, not as much tibiofemoral osteoarthritis. So just a little bit of information you can use for your physical examination. From a differential diagnosis perspective, what else do we want to be on the lookout for? So these are interesting and sometimes not on our radar as far as, orthopedic issues, but we should be conscious of these. But inflammatory arthritis, so rheumatoid arthritis, as well as psoriatic arthritis, also infectious and crystalline arthritis. So things like gout and pseudogout, right? How do we know the difference between the two? So the infectious, inflammatory, and crystalline arthritis, they generally present as a warm, easily palpable effusion, and they are very inflammatory in nature, so it makes sense. It's just very warm, very swollen. You might think it might be more of one of these inflammatory arthritis issues, not necessarily OA. Essentially, you would send these folks back to the doctor. They do some lab testing. Maybe they withdraw some fluid from the joint. And essentially, if you have synovial fluid with white blood cells exceeding 2,000 cells per cc, that would be indicative of having more of an infectious, inflammatory, or potentially crystalline arthritis. When in doubt, refer out. If you have a patient that's not getting better, refer out, right? If it looks like they have an infection, refer them out. If it's like a red joint, like that's not good. It might end up being just arthritis, but refer out to be safe. And also soft tissue lesions, which often masquerade as knee arthritis. It's hard to tell the difference. So if you have a meniscus injury, particularly a chronic meniscus injury, which are also very common with knee osteoarthritis, and the last patient that I saw, I thought they had knee OA, ended up they just had a new meniscus tear, right? Seems a lot like arthritis. So if you have joint line tenderness, if you have pain with the range of motion, you have swelling, could be a meniscus injury, could also be knee osteoarthritis, right? If you have a ligamentous injury, particularly, let's say ACL, PCL, going to create some swelling, potentially create some injury. Maybe it's an MCL, it's more local tenderness, but maybe it's joint line tenderness. May seem a little bit like knee osteoarthritis. I think age is a big one. You don't have a whole lot of 60-year-olds playing soccer, but I have some of them, right? And it might be more arthritis or it could be more ligamentous. And obviously it could be bursitis, tendonitis. You just have to do your due diligence. I'm not going to list every single orthopedist test in the world, but make sure you do a well-rounded clinical examination. I think the other one is that what is their history and what is the person in front of you? You have a 65-year-old African-American woman with knee pain. I'm starting to think knee osteoarthritis from the beginning, right? And not like a new ACL tear, right? And just see the other lessons if you want differential diagnosis. We have a lot of that. So take a little breather. Any other clinical pearls or anything there, Kevin, before we move on?
Yeah, no, I think that was good. And I think it's good to hear about the cyst. I have a patient right now, a slightly older guy, probably in his early 60s, who had an MRI and they found a cyst in his knee. Definitely has pretty significant arthritis. And he was wondering how common the cyst is. And I think a lot of patients, if they don't know a lot about their anatomy or whatever, he was worried the cyst was going to be like cancerous or something like that. He's like, why is there a cyst in my knee? So it's good to hear that those are fairly common in this population. And then I agree with you on the swelling. I mean, I do feel like I see swelling and changes in swelling in my patients with knee arthritis, but perhaps there's something else going on as well. Maybe it is a chronic meniscus tear and arthritis. I'm sure multiple things can be true, whether the arthritis is causing the swelling or not. But I would think with that chronic inflammatory process, you would see swelling as well. So I don't think it swells as much as like a ligament injury, but it does seem like there might be swelling there, and maybe other things are going on as well. But I think that's helpful for people to see and hear. So yeah.
Yeah, one of those hallmarks that I typically see, and again, maybe I'm wrong, but people with like a knee with quite a bit of knee OA, I always just look at it. It's big, puffy,
Yeah.
swollen, right?
Mhm.
Um, but yeah, just a little interesting thing. One of those things that contradicts what I've seen. And maybe it's specific to the joint effusion. Maybe those guys have more generalized swelling, not
Yeah.
necessarily like that positive sweep test kind of thing. I'm not really sure, but just interesting, something I saw. So
And that, yeah, clinically definitely just stiffer, like stiffer in all directions. That's that global stiffness. You start thinking more intra-articular for sure. Yeah.
for sure. Also, we can use some radiographs for diagnosis. There are a bunch of different grading classifications for knee osteoarthritis. Probably the most common one is the Kellgren-Lawrence scale. And essentially, this is all done via x-rays, right? And essentially, if you have grade 1, it's questionable that you have osteophytes. So it's not quite, plain to see that you have a bunch of additional bony growth. And that was like the first grade. So it's very low level osteoarthritis. Grade 2, you can see osteophytes pretty clearly. So you'll see some of those overhanging osteophytes in the x-ray. Grade 3, you have definite joint space narrowing. In grade 4, you have advanced joint space narrowing. I think that when you hear the whole bone on bone, usually this is because you can see that there's no joint space anymore. And essentially you have one bone contacting the other. In terms of an MRI, generally it's not needed, meaning that you can detect this via an x-ray, although it might be helpful to detect soft tissue injury. I know a lot of physicians I've worked with will take x-rays, they won't see much, and then they'll end up doing an MRI. And what they will see is some of that synovitis. So it kind of lights up. You can see some inflammation. They're like, well, the x-ray looked pretty good, but now we're seeing that there's actually quite a bit of inflammation and contact potentially in these areas. And that kind of correlates a little bit more with your symptoms. So kind of an anecdote, but that's what I've heard. And obviously you can pick up soft tissue injury. So if you're not sure if this is a new meniscus tear or osteoarthritis, you might be able to see more of that via the MRI to help with differential diagnosis. And I took this from one of the studies, which I thought was interesting because they're using a combination of clinical tests as well as radiographs to help to rule in symptomatic osteoarthritis. And they're using sensitivities and specificities, which is kind of cool. So if you're seeing bony enlargement on radiographs, it has a sensitivity of 55% and a specificity of 95%, right? So if you're seeing that, it's pretty good for rolling it in, but not very good for rolling it out. If you have crepitus with passive motion, so that's something that we can do, actually has a pretty good sensitivity. So if there's no crepitus, good chance you don't have osteoarthritis. But like I said previously, the specificity is bad. You can have patellofemoral pain and no OA and still have a crunchy knee, right? The presence of osteophytes, high sensitivity, 91%, and fairly high specificity as well. So it's just a sign that like, hey, if you got bone growing within that joint, chances are that you probably do have osteoarthritis. And the other one was knee pain plus osteophytes, had a lower sensitivity, 83%, but a higher specificity, which kind of makes sense. Like your knee hurts and you've got osteophytes. It's like, all right, those are two hallmarks of knee osteoarthritis. Maybe that just rules it in a little bit better. So thought that was interesting. I didn't know about this, but kind of cool because you can use some of the x-ray in combination with the clinical assessment. I can pretty easily see a surgeon using this together, showing this to the patient and saying like, well, based on these findings, we can either kind of help to rule in or rule out osteoarthritis, which was kind of neat to see.
Nice, dude.
Nice. Any particular thoughts with that, Kevin?
No, that was good. I think the bony enlargement, I know you said on an radiograph, but I do think when you mentioned the swelling and the knee joint just looking bigger, you kind of see that in those arthritic knees. I think especially that have been going on for a long time is whether it's swelling or it's just the continuous like mechanical load to the bone and it's not going to the cartilage anymore, that you do see the bone thickening in response to that. So yeah, that's interesting. And I think probably goes into the diagnostic process with the orthopedic. So pretty cool.
Yeah, you can kind of see it and know what it is, right? You got these, kind of reminds me of like an old tree, essentially like you'll see a big prominent knee joint. Oftentimes there's a lot of swelling. Sometimes there's that varus or valgus deformity, right? Kind of big knobby knee. And then sometimes there's like no muscle above it because they have so much atrophy from years of pain, just reminds me like an old knobby nodular tree out in the woods, just kind of like half bent over, right? It sounds terrible saying that, but you can kind of like recognize it when you do see it.
You're such a tree guy. You're such a tree guy now.
I am. I'm big time in the trees now. It's my thing. All right, but enough about trees. Let's talk a little more about the knee. So largely, you're an expert now, knowing the basics about knee osteoarthritis, but sometimes when someone has a swollen joint, it might not be knee osteoarthritis. It might be chronic meniscus tear. And you need to know about that. And we have the video for you. And it's living right over Kevin's head. If you click on that, we'll go over what PTs need to know about meniscus injuries. And we'll see you there.
If you're watching this on YouTube, please, please, please hit that like button. Consider subscribing to the channel if you enjoy this. If you're listening to the podcast version of this, please give me a 5 out of 5 rating. It helps tremendously. And lastly, if you want to go that next step and support me further, consider subscribing to Fitness Pain-Free Insiders. So Insiders is like Netflix for physical therapists and coaches working with painful folks in the gym. You've got access to 100 plus webinars, ebooks, and courses. More recently, I've been taking all of my best content from YouTube. I've been taking out all the ads. I've been organizing it in a really step-by-step fashion in an entire course so you can easily go through it. And I add additional pieces to this to enhance your learning, right? So I just finished up my lateral ankle sprain course. And one of the big things I added to this was a protocol. So essentially, what do you do week 1, week 2, week 3, week 4, week 5, 6, 7, 8? You know me, I like working with athletes. I like working with really fit and strong people. So it's going to be a lot more robust than your typical protocol. Also, you have access to me. So inside of Insiders, you can leave a comment and I'll get right back to you. I also have physical therapy CEUs inside of Insiders. So if you take the course, Essential Coaches Series, get a bunch of CEUs. And what's even better is you can start for just $1. After that, it's $25 per month. It's going to be the cheapest CEUs you can get. It's by far the highest value program that I offer at the cheapest price. So head over to fitnesspainfree.com, click on the program's link, and then click on Fitness Pain Free Insiders to get started. I'll also leave a link in the show notes where you can check it out.